The patient is positioned on the hip distraction table with the perineum against a silicone padded post. Feet and ankles are well padded to prevent injury and then placed in traction boots. General anesthesia is administered and muscle paralysis is verified. Fluoroscopy is utilized to verify a positive vacuum sign. The patient is then draped and prepped with the traction off, and after verification of anatomical landmarks, traction is reapplied. In those cases where it is felt there is not enough clear space to allow safe placement of the hip obturator and cannula, the head drop technique is employed. These situations may be encountered with coxa profunda, cranial retroversion of the cup, coxa vera, large os acetabuli, and in cases of resistant drug relaxation, allowing sufficient time for motor blockade to take effect, which in our case tends to be 5 to 7 minutes. At this point, reapply incremental traction in preparation for portal placement. Ideally, 9 mm of clear space is optimal for portal placement. If safe placement cannot be assured, perform the head drop technique with fluid distension. The anterolateral portal is established using a 17-gauge cannulated needle with 25-degree inclination to the joint and placed parallel to the floor or with a slight posterior tilt. Remove the stylet from the needle, which vents the joint and alleviates any negative pressure that may resist joint distraction. Prepare a syringe of 40 milliliters of saline and attach the syringe to the cannulated needle. Inject a small amount of fluid into the joint. Proper positioning of the needle within the central compartment is verified by brisk fluid egress from the needle. Next, inject fluid until a firm resistance is met, usually approximately 30 milliliters of saline. Quickly remove the entire needle and syringe, trapping the fluid within the joint and allowing the head to drop or migrate distally with joint distraction. With adequate joint distraction, reinsert the needle into the central compartment close to the femoral head. Remove the stylet, upon which a brisk fluid return should be noted. Reinsert the nitinol wire, followed by the 5 mm obturator and cannula. In cases where limited distraction still exists, utilize a 4.5 mm obturator and cannula initially, and then dilate the portal prior to re-entering the joint with a 5 mm cannula over a switching stick, which improves fluid flow. In conclusion, intra-articular fluid distension is one of many existing techniques that can be employed to minimize iatrogenic injury to the chondral surfaces and labrum upon initial portal placement. The appeal of this technique is that it is simple, safe, reproducible, and reduces the amount of traction that is required to achieve adequate joint distraction for initial interlateral portal placement during hip arthroscopy.